but I've got a 58-year-old woman whose lifelong cholesterol is 9.5 millimoles per litre. And she tried statins, couldn't lift her arms after a few days because of the severe myalgia. And she saw doctors, if you don't take Lipitor, you're going to die. All this scaremongering nonsense that you get all the time. She came to see me, sent her downstairs for a calcium score, 0. So in her case, her cholesterol wasn't spilling into her arteries. So for the next 8 years, every scaremongering doctor said, if you don't take Lipitor, you're going to die. Rubbish, rubbish, rubbish. So she came back to see me 8 years later for another calcium score. Cholesterol still 9.5 because it's all genetic, as you know, and familial hypercholesterolemia. And a calcium score was still 0.
Welcome to the Fat Emperor podcast. I'm your host, Ivor Cummins. We're supported by the Irish Heart Disease Awareness Charity, which advocates a simple CT scan to reveal your CAC score. So, know your score and take action to prevent that premature heart attack. Everything you need to know will be right here. Really looking forward to today's conversation. I'm with Dr. Ross Walker, who's a preventative health expert in Australia, discovered calcium scanning decades ago and has carried out an enormous number of scans and has gained huge insights into the technology. So great to meet you, Ross.
Great to talk to you, Ivor. Thank you very much for having me on the show.
Oh, I'm delighted to have you on because we both have a mutual friend who is not 100% convinced with the high value of scanning, and you had a chat with him in Australia and seemed to have pretty much convinced him.
Well, I think the point about calcium scoring is that you have to really understand what it does and you have to have experience with it. Now, I introduced calcium scoring to Australia in 1999 and I copped it from, shall we say, the more conservative elements of medicine. And now it's been overtaken by this CT coronary angiography. And I really object to this because there is not one scientific paper in the peer-reviewed literature to show any prognostic value of CT coronary angiography over coronary calcium scoring. But the difference is, in my country, when you have a coronary calcium score, it's probably around 10 chest x-rays of radiation, which I think is a good way of thinking about it. It costs in Australia about $150, whereas the CT coronary angiogram costs you $500 to $600 more. You glow in the dark for a few days afterwards because of the radiation dose, and it requires an intravenous injection that potentially you could have an anaphylactic reaction to. And also people aren't thinking about the potential effects on your kidneys of having intravenous dye as well. So I say stick to the coronary calcium score for screening asymptomatic people as a risk for cardiac disease. And it's my view that all males at age 50 should have a coronary calcium score as routine health screening. All females at age 60 should have it. Now, if people are listening to this and they've already had a heart attack, stent, or a bypass, coronary calcium scoring is completely useless for those people. You've already had your problem. You don't need to have the fact that you've got heart disease confirmed. And also, once people get up to scores of around 300 or above that, I never repeat the test. And it's got nothing to do with the inaccuracy of the test. It's because you can't guarantee, A, that you're scanning somebody again 5 years later on the same machine. You can't guarantee that they take the same breath hold, that you're starting from the same spot with the scanning, you're hitting them at the same part of the cardiac cycle. And the problem is you're getting a two-dimensional still image of a three-dimensional moving object. So once you get up to 300 or 400, you can miss 100 either side of a plaque. And so someone will focus on the score and go, oh, I've gone from 400 to 600, when really it might be around the same amount of atherosclerotic burden.
Right, okay. So that's interesting because if, for instance, I would know people who'd have a score around 1,000 and over the years they'd verify, actually I work for IHDA and David Bobbitt, the founder, had a score around 906. And he verified over the following 7 years that he's only now up at 1,100. So I agree there's a variability, I mean, plus or minus 100, but he's shown that he's effectively gone down to an average of 5% per year, approximately. So he's very, very different than someone who could go 9, 12, 14, 1,700. So would you see value there in terms of monitoring?
Yeah, to an extent, I would, but I find that I do a test called applanation tonometry, which measures arterial stiffness. So it's just a little probe over the radial artery at the wrist, completely painless. And it's been pioneered by a few people in England and in Europe as well, in France as well. It's a really good, simple test. And I use stress echocardiography. And if I see improvement in arterial stiffness, which is completely non-invasive, much cheaper, painless, and doesn't involve any radiation at all, and with stress echocardiography, that again is no radiation, you can see that the heart's nice and stable, and you use your blood test to verify that as well. And also the point about coronary calcium scoring is that I just feel we're looking at numbers too much. All I'm really interested in, Ivor, is that people are either in the very low risk range, which is 0 up to about 10, the lowish risk range 0 to 50, low risk 50 to 100, medium risk 100 to 400, and above 400 I say is don't read Tolstoy. But getting onto the radiation issue for a second, I say there are only 3 advantages of being over the age of 50. Number 1 is wisdom. Number 2 is grandchildren. And number 3, you lose the sensitivity to medical radiation. So you're not going to get a cancer out of a calcium score or an intravenous CT angiogram or a nuclear scan. A lot of people don't talk about nuclear scans. There are about 300 chest x-rays of radiation. So I like to limit radiation to people below 50 and only focus on people above 50. But I'll give you a couple of interesting examples. I have a 32-year-old female patient, and I would almost never do coronary calcium scoring on that group of people, but her father died at 31 of familial hypercholesterolemia. Now, her cholesterol level is 12.4, so I sent her down for a coronary calcium score, and it came back at 48, in the middle of the mild range, but a huge amount for a 32-year-old woman. So I'm hammering her with statins because she has severe hypercholesterolemia and already coronary calcium and a strong family history. But I've got a 58-year-old woman whose lifelong cholesterol is 9.5 millimoles per litre. And she tried statins, couldn't lift her arms after a few days because of the severe myalgia. And she saw doctors, if you don't take Lipitor, you're going to die. All this scaremongering nonsense that you get all the time. She came to see me, sent her downstairs for a calcium score, 0. So in her case, her cholesterol wasn't spilling into her arteries. So for the next 8 years, every scaremongering doctor said, if you don't take Lipitor, you're going to die. Rubbish, rubbish, rubbish. So she came back to see me 8 years later for another calcium score. Cholesterol still 9.5 because it's all genetic, as you know, in familial hypercholesterolemia. And a calcium score was still 0. And so in her case, she doesn't need statins. So there was a beautiful study from in the Journal of the American College of Cardiology, October in 2015, where they looked at 5,000 people over 10 years. 77% of the people in the trial fitted the US criteria to be on a statin, but half of them had a 0 coronary calcium score. And those who did, their event rate was so low over the 10 years. The conclusion of the trial, statins are worthless for people with low or 0 coronary calcium scores. So it just annoys me that people aren't looking at coronary calcification as the best risk marker for heart disease, not cholesterol. I think cholesterol is overdone.
Yeah, I'd certainly agree on the cholesterol point. And just to your examples there, I know they're just n equals 1s, but I have a guy in the US who's 29-year-old and his father died at 38 of a massive heart attack. His cholesterol wasn't high at all, and they didn't want to give him a scan. And he eventually pushed through, because I've been pushing this out there on the web. He got a scan and he was 600 at 29 with relatively low cholesterol.
And he needs aggressive risk factor modification. I would give him statins. I might even think of something like that with a PCSK9 inhibitor. I'd hammer his LDL down to very low levels. But in my country, there are 19 million prescriptions written for statins every year. So that's 12 scripts per person per year, because our scripts go for a month. And so it's just under 2 million of the Australian population are being given statins. And I would suggest to you probably 1 million of those scripts are necessary. Now, when we're talking about calcium scoring, the worst calcium score I have is a 68-year-old man in the fitness industry doesn't have an ounce of body fat, normal cholesterol, normal blood pressure, never smoked, not diabetic, no family history of heart disease whatsoever, but has an elevated lipoprotein little a. His coronary calcium score is 8,500. So his arteries are like porcelain pipes. He's had coronary artery bypass grafting. He's now doing extremely well. So you have to, you see, I don't treat cholesterol, I treat risk. And the best indication of risk is an overall risk assessment, which includes the coronary calcium score and a new test called the PULS score, the PULS score out of America. And this test looks at 7 biomarkers that are elevated in people with vulnerable plaques, because the calcium score tells you that you have plaques, but it doesn't say whether they're stable or whether they're vulnerable. But the PULS score then adds to that by telling you that you have unstable plaques, and if you do, they're the people who you should be more aggressive with your risk factor modification.
Right, and that pulse score, I'm vaguely familiar with it, but I'm guessing inflammatory markers are like LPPLA2 or plaque2, those kinds of tests looking for...
Yeah, you're right, but they're even more esoteric than that. So there's all these different, like FAST2 and oxidized things. So it's a whole lot of different things. I could send you the list, but it's not worth rattling them off right now. And they look at HDL and HbA1c and age and family history, and they give you this score. And it's like a Framingham risk score over 5 years. They give you the score, and you look at that. So I think that's a really good thing to do as well. And the other interesting thing with all of this in terms of risk assessment is that when I look at going back to the calcium score, when I look at the calcium score, it's not just the score, but it's the volume. And a lot of people don't get this. So just say, for example, you have a coronary calcium score that starts off at, say, 80 and your volume 60. I've had a number of patients who've then gone up from 80 up to 200, but their volumes dropped down to 40. Now that's telling me their arteries are just becoming more stable and the volume's contracting, or in other words, you're removing fat from their arteries. Because in reality, we don't want to get all the calcium out of people's arteries. We want to get the fat out of their arteries. And that's what comparing the calcium score to the volume tells you. And I have a number of patients in my practice who, mind you, 10% of my patients can't tolerate statins, but I've had a number of patients who followed all the right lifestyle principles and taken some other natural therapies that I'm more than happy to talk about. And I've been able to reverse their disease on the calcium volume as opposed to seeing the progression of the calcification. So you have to take all of this into perspective and not just focus on one marker. And there's a few other very good risk assessment techniques that people aren't talking about. And one very good one is a thing called the omega-3 index. And the omega-3 index, as you're probably well aware, measures the amount of omega-3 you have in your cell membranes of the red cells. And most in Australia, we have a reasonable amount of fish, but the average omega-3 index is around 4%, which is very poor. In places like Japan, where they have a huge amount of fish, that goes up to 8%. And there was a study in the New England Journal of Medicine a couple of years back by a Dr. Harris and colleagues, showing that the omega-3 index is a much greater risk protection than cholesterol. So there's a whole lot of other things we need to think about as opposed to just this obsession people have with looking at damn cholesterol levels.
Yeah, the cholesterol has been an enormous distraction, really, in many ways over the decades. So, and I talk quite a lot about that in my talks and other podcasts. The omega-3 index, couldn't agree more. It appears to be a very powerful marker of health, and there's a huge body of science around that ratio of omega-3 to omega-6 in the red blood cells, and how it indicates a lower inflammatory state and a much healthier physiology. So I think Omega Quant and other companies give the test, and they kind of recommend over 10 ideally, as you say. And I think America's an average of 4 point something as well, and it could be a huge part of the massive heart disease in America compared to these other countries for sure. So when you talk there about volume and density, yeah, that's a very important point. It was raised to me by Dr. Michael Eads in the US a couple of years ago, and he sent on some papers, and they were fascinating, where they actually looked, and there was a hyperbolic kind of relationship that as Agatston overall score went up, risk went up, but as density was high, but volume was relatively low. Risk went down again, more like a low scoring person. So I put that out there quite a bit just to show that it's nuanced. And he has also seen people who have gone to a lower carb diet when they've had diabetic dysfunction and their health has improved markedly and their score has continued to rise a little over the following years, but the relative volume is stable or dropping. And I guess it's just the body continues to do the repair process. You know, there's inertia, it continues, but it's not going up like Heinz-Nixdorf study. It's not going up 20-25% a year and volume and density both rising, which is the dangerous thing, yeah?
Yeah, exactly. And that's where I think so many people do not understand coronary calcium scoring because they purely focus, as you say, on the density and not looking at the two things together. And I always compare when I'm doing follow-up scans in my patients at a lower risk. And another point, seeing we're talking about all the aspects of cholesterol, but I think people are missing out. When you look at, say, for example, familial hypercholesterolemia, which is only really 5% of coronary artery disease, but it's a very good model for this discussion. If you look at that, 50% of people with familial hypercholesterolemia by age 50 will have a vascular event. Now, if you're an optimist, 50% of people won't have a vascular event. And I'm finding that the people who don't have the vascular event in that 50% of people are people with a significant amount of large LDL cholesterol. Because it really annoys me when people get so focused on the LDL, which is just, as you know, an extrapolated figure on a blood test, whereas really it's looking at the subfractions. And if you have small, dense LDL cholesterol, that is obviously pro-atherogenic, whereas large LDL is important. We need it for cell membrane function. We need it for cell metabolism, bile salt metabolism, steroid metabolism, vitamin D metabolism. So we have to have a reasonable amount of large LDL and also large HDL. And a lot of people don't realize that small HDL is pro-inflammatory. So I say to people, this is where size is important. The larger, the better. So get your LDL large, get your HDL large, and statins don't have a huge effect on pushing you from small to large. But there are, you've already mentioned one very important thing, which is going on a low carb diet. That pushes you to large LDL. So a lot of people will start off with a cholesterol of, say, 4, triglyceride of 2, and an HDL of 0.9, and then they'll go onto a low carb diet. Their cholesterol goes to 6.5, but their HDL also goes up and their triglycerides drop. They think they're getting worse because their cholesterol's gone up, but they're actually getting better because they're getting more large HDL and large LDL.
Yeah, exactly. And effectively, any diabetic physiology they have, even if undiagnosed, they're resolving. And that's kind of the biggest driver of heart disease in the world, arguably. So, yeah, it's the right way to go. Interestingly, on familial hypercholesterolemia, there are many papers. I think I gathered around 6 or 7 studies. And the people who get heart attacks really early, FH people, these are proper genetic identification, not just that they are identified by having high cholesterol. But the people who get early heart attacks versus those who age and have no heart disease whatsoever, they have the exact same level of LDL, pretty much.
Yep. But it's small versus large. That's what
Absolutely. And there are many other papers showing that the HDL level and certainly size and the ratios of the cholesterol, which indicate your degree of insulin resistance, are hugely important in deciding who with FH is a problem or not, exactly as you say. So I guess FH people, for me, they've got a genetic susceptibility to heart disease, but it's mediated really by the same kinds of problems that give non-FH people heart disease, right? The same kind of issues. Yeah.
And if I can pick you up and agree on a vital point you made before. It's my view that 70% of heart disease is directly related to the insulin resistant gene, 20% due to lipoprotein delay, and 10% due to the less common genetic abnormalities such as FH and problems with ApoC and a few other things that go along there. So really we've got to be focusing on this big population of people who are insulin resistant, which in my view is 30% of Caucasians, 50% of Asians, and close to 100% of people with darker or Mediterranean coloured skin are the people who are born with the gene for insulin resistance. And as soon as you expose them to Western rubbish, that's when they start to get all the problems with vascular disease. Whereas the Lp(a), you can be a Franciscan monk or a profligate self-abuser, it can still get you at any age. depending again on how much small LDL is in the Lp(a) head, the LDL on the head of the Lp(a). So if you've got a lot of small LDL, because if you line up 100 people with a high Lp(a), about 70 will have a vascular event in their life and 30 won't, and the 30 who won't have large LDL in the LDL head, whereas the other 70 have the small LDL.
Yeah, and yet again, I guess Lp(a) in a sense indicates a susceptibility which may or may not come to pass depending on the other important dynamics. It's interesting with Lp(a). I have a disclosure, I have super high Lp(a) and I have really high particle count as well, but I have a zero calcium score at near 50. But we have guys in their 60s and gals with zero calcium scores, and even a couple that got the angio who are pretty much amazingly clear. And some of them, the highest LDLs we have there are up to 9 millimole of LDL, and even some super high Lp(a)s. Now 9 millimole, that's for the Americans 360 milligrams of LDL alone, zero in their 60s. So your point is well made. The cholesterol will hopelessly mislead you. I always kind of indicate, look at it as a pointer, particularly look at the ratios or the small dense measurements, which are more, indicative. But then, of course, get a calcium score and find out if you have a problem or not. I mean, that's the bottom line.
Yeah, but you'll always get these people who'll trot out the very occasional situation where someone has a zero calcium score, but on the CT angiogram they saw a 70% block. Often, when you do the proper angiogram, it's a 30% block. So I believe CT angiogram often overcalls the severity of obstruction. And to trot out one example when you might over-radiate and over-investigate 99 people who don't have any problems with a zero calcium score, my friend and colleague Matt Budoff in California, who I'm sure you know very well, Matt says beyond a doubt the calcium score is the best predictor for heart disease. It's been proven time and time again. But can I make another point, which just when we're talking about prevention here, I get a bit disturbed by the excessive focus on drug therapy. And the reality is that, and I'm quoting here the Morgan trial, and the Morgan trial backs up what I call the 5 keys of being healthy. And this is in increasing order of importance. Number 1, you cannot be healthy and smoke, drink too much alcohol, or snort cocaine. So anyone who has any addictions to anything is sick, number 1. Number 2, we don't focus on this enough, is 7 to 8 hours of good quality sleep every night is as good for your body as not smoking. And there's a recent TED talk called Sleep, the New Superpower. It's a brilliant talk. Number 3 is the third best drug on the planet, which is nutrition. And nutrition is easy. It's called eat less food and eat more natural food. And the best studied diet in the world is clearly the Mediterranean diet, which basically is based around 2 to 3 pieces of fruit per day, 3 to 5 servings of vegetables per day, and little bits of meat, eggs, dairy, chicken, fish, nuts, grains, and olive oil. It's a very simple diet, and it actually has some long-term science behind it. Number 4 is the second best drug on the planet, 3 to 5 hours every week of moderate exercise. And number 5 is easily the best drug on the planet, a thing called happiness. And a 75-year study from Harvard released a couple of years ago showed the one key to health and happiness is to have someone else in your life who loves and cares for you, who you love and care for. And I don't think we focus enough on the vital importance of those 5 keys. And the Morgan trial showed, M-O-R-G-E-N out of Holland, showed that if you follow those 5 keys, so the people in the highest quintile versus people in the lowest quintile, an 83% reduction in cardiovascular disease with no side effects. If I give you a statin drug in an average dose to lower your cholesterol, that's about a 20 to 30% reduction in cardiovascular disease and a heart attack. If I give you in a high dose from things like the Jupiter trial, in say 20 milligrams of rosuvastatin, that's a 50% reduction in cardiovascular disease, but with the potential for a bucket of side effects. And it's my view that the side effects are underreported in clinical trials. So for example, let's pick on myalgia, which is probably the commonest side effect of statins. Myalgia is reported in less than 5% of people in clinical trials, but they have a very strict definition of myalgia, muscle pain with a CK level 3 times the normal level. Whereas I see so many people who get pain without a CK rise, stiffness in their muscles, weakness, cramping, and even loss of muscle bulk with no effect on their CK at all. Now, they wouldn't make it to the clinical trials, and I would suggest to you, Ivor, that's about 20% of people. I do not personally prescribe as a cardiologist fat-soluble statins, atorvastatin and simvastatin. I don't prescribe them at all because I believe they penetrate through the membrane so much more because they avidly bind to a fatty membrane. And in a healthy person, the membrane of the cell is 75% fat. So they're ripping out healthy cholesterol out of the cell membranes. I only prescribe the water-soluble statins, rosuvastatin and pravastatin, and only for people that have either a high coronary calcium score or proven pre-existing heart disease. They're the only people I give statins to.
Yeah, and that lines up exactly with myself, IHDA, and I think Dr. Seem Malhotra, a friend of yours, who is
A very dear friend of mine, yeah.
exactly the same thing. It's not anti-statin, generic kind of belief system. It's for high calcium score, proven heart disease, prior event, people who have disease. And there was a beautiful study done. It was associational, and it might have been the one you mentioned. Joshua is the lead author. It was late last year it was released, and it essentially tracked the people who had scores, all the brackets of calcium scores, and whether they were taking statin or not. And they tried to standardize all other confounding factors. The result they got was 0 to 100 calcium score, statin over 12 years showed no relative benefit. And over 100 score and over 400, there was a 30 or 40% relative risk reduction of events. Relative. So in fairness, mortality is a smaller effect, but relative. But it just illustrated again, the statins mitigate the disease process, stabilize the plaque in people who have substantial active disease. But they only have room for potential harm in people where there's no particular burden of disease to actually mitigate. It seems so obvious in a way.
Oh, and can I also make the point here that all the studies that show a significant benefit from statins are typically done in, shall we say, overweight Americans and overweight people who don't have a healthy lifestyle. And there are actually no studies done of statins in people who lead a very healthy lifestyle to see if they really do give added benefit. And we're extrapolating evidence from people who are at very high risk for heart disease or have already had heart disease down to the low risk population. So I'll give you a very disturbing example. And now these are, as you said before, N equals 1. This is an anecdote, not a clinical trial. But I saw a patient I've been looking after for a couple of years the other day, just reminding me of this story. He was started on statins at age 23. Why? Because his cholesterol was high. And at age 53 or age 50, came to see me with the story that he'd not had one, not had two, not had three, but he'd had three separate cancers. Now, we're not talking about a cancer that spread to other places. We're talking about thyroid cancer, bowel cancer, and prostate cancer in the one person over 3 years. Now, I've got to say to you, I don't have any clinical trials to back up what I'm saying, but I only see these multiple cancers in people who've been on long-term fat-soluble statins. So that's why I don't use them at all. I only use the water-soluble ones. I haven't seen it in people on water-soluble statins. I saw another fellow who'd been on 10 milligrams of atorvastatin for 8 years, and within 6 months had 4 different cancers, 4 different primary cancers in his body. So I just think we've got to be a bit circumspect about who we throw these drugs at. I saw another 35-year-old man who came to see me with a high cholesterol. He was on 40 milligrams of atorvastatin. I said, "What are you taking this for?" He said, "Because I've got a high cholesterol." I said, "Yeah, what are you taking this for?" And he went on to tell me that his wife had been through 3 unsuccessful cycles of IVF. And I said, "Well, it could be the atorvastatin. Stop it." Within 6 months, she got pregnant without any intervention whatsoever, apart from the obvious one. So seriously, I just think that the first line of the Hippocratic Oath is first, do no harm. So this is my argument. If you have a high coronary calcium score or existing heart disease, there's your 10-year risk for a heart attack. So therefore, statins might be worthwhile for you. Whereas the 10-year risk of statins is about here. If your coronary calcium score is low or zero, there's your risk. So why would you take a drug that has a potential risk to your body more than your pre-existing risk? And you mentioned before, the 30 to 40% reduction in a disease, if your starting risk is 5%, you're taking your risk from 5% down to 4% over 10 years. Which person in their right mind would take a strong synthetic drug for 10 years, profoundly affecting their metabolism, for an absolute 1% reduction in risk? I mean, I think it's just craziness, but people are doing this all the time. So I say, look at your initial risk. And in fact, there was a study that was released in the Annals of Internal Medicine only a couple of weeks ago that showed that the only people who derive benefit from statin therapy are people who have an estimated 10-year risk of 15% or above. Now, I'm hearing a lot of my colleagues saying as soon as the risk gets to 7.5%, we should be giving them statins. There is no scientific evidence at all to support that view.
Yeah, and I think to your point, even if there's a relative benefit that's of a similar magnitude, the absolute becomes small enough that why would you take the risk of permanent daily medications with potential effects, you know, to have an absolute risk so small a drop? It just doesn't make sense. But I guess the medical people, the busy doctors all around the world, I don't think they're dissecting these numbers. They're busy people. They just accept, oh, it reduces the risk a lot. And B, it's something I can do for the patient, because at most doctors, giving the patient the right dietary advice or low carb, they're not even going to be giving that. And if they give it, it feels like kind of naturopath diet and lifestyle, you know, treatment. It's not what the patient paid for. They paid to get some magical drug. Is there a lot of that psychology with most doctors that, well, I can give a pill that reduces the risk and I can do something in minutes?
Look, can I say the whole system is beautiful, and it's a beautiful game that's disgraceful. Let me tell you what it is. The fat guy goes into the doctor and says, "Doctor, I've got cholesterol." And the doctor doesn't say, no, you're a fat slob, you need to lose weight. The doctor says, "Oh, I can fix that. Lipitor, next." So the script's written for Lipitor. The fat guy walks out of the doctor's office and goes, "Oh, phew, I didn't get a lecture about being fat. I can just take this and eat what I like." Now that really disgusts me, that whole inference that the key to good health is lowering a number in your bloodstream with a pill. And that you can eat what you like because you're keeping your cholesterol low with a pill, which is rubbish anyhow. And it's dismissing the whole fact that eating good quality foods, you're getting high quality micronutrients, high quality macronutrients into your body that are not only affecting maybe your lipid profile in a positive way, what you and I were saying about shifting you from small to large LDL, very positive, but it's also making your blood more fluid. So you're getting much less thick blood, to use the Reader's Digest term. You're also getting the anti-inflammatory immune support of a good quality diet. And also, if you have a diet that's high in, and this is the only problem where I have an issue with fat, is if you're getting trans fats, the synthetic fat. And a great con job that happened in New York a few years ago is that they had these big signs at all the restaurants: "We no longer cook in trans fats," because they use a different process called interesterification that still creates synthetic fats. So you're still getting the same effect that will thicken and harden food, and it thickens and hardens the cells and the arteries when you have trans fats and processed carbohydrates. So I say to my patients, don't have processed packaged muck masquerading as food. Don't have that, and get rid of white death. What is white death? Sugar, white bread, rice, pasta, potatoes, go straight to the gut. And I don't know what wheat you have there in England and Ireland, but what we have in Australia is this hybridized wheat called Triticum estevan, which is full of gluten. So every second man and his dog in Australia is gluten sensitive now. And also they're getting a huge glycemic load from the gluten in the wheat in Australia. So I personally believe you've got all the dietary stuff wrong. Encourage people to have good quality fats, which, let's get onto this, includes saturated fat. You're probably well aware, I know you would be with your title, well over the PURE study. The PURE study, the two beautiful components of that. The first one, 135,000 people in 50 different countries over 9 years, showing the highest intake of carbohydrate, 28% increase in death. The highest intake of fat, 23% reduction in death. The highest intake of saturated fat, 14% reduction in death. And the bit they released last year when they put in a few more cohorts, 220,000 people now in 50 countries, the biggest dietary study in the world, over 9 years, showed that if you had 3 serves of high-fat dairy per day and 100 grams of red meat, 25% reduction in death and cardiovascular disease. So anyone who says to you saturated fat causes heart disease, and still there are many cardiac associations around the world putting this up on their websites, hasn't looked at the latest literature.
Yeah, I did. The saturated fat thing is somewhat of a farce now over 50 years, I agree. And even though Pure was associational, it was a 20 PhD MD team. They did all the statistical analysis to have it as minimally confounded as possible. And to be honest, it overturned the previous associational epidemiology that suggested fat was a problem. So the whole thing's a net. It was all kind of an illusion the whole 50 years. But you're right, the organizations, after prescribing lowering saturated fat and fat for 40 or 50 years officially, it's obviously extremely difficult for them to admit they were wrong. I mean, there's huge stakes. So I think they're compelled to keep the myth alive for a little longer to ease their way out.
I wouldn't say a little longer, my friend. I think they're compelled to keep the myth alive, because if you're a supposed expert in the area, and you come out and say, you know what, guys, for the last 25 years, I've been wrong, you look like such a total idiot. No one's ever going to believe you have any credibility at all. So you have to keep pushing the barrow of low fat this, low fat that. And you and I both know it's complete nonsense.
Complete nonsense. And the American Heart Association, American Diabetes Association, but then all the nutritional and dietetic associations and all the government bodies. So we're talking about, that's not just a small group of academics there with an enormous face to lose. You're talking about kind of everyone in authority in medicine and nutrition. So you can imagine the power of that phenomenon to keep this myth going. It's enormous. I agree. It's going to last a long time. Now, there is a potential exception to the rule. Just one worth mentioning, that Dr. Stephen Gundry, and I'm trying to get him on the podcast, has worked a lot with ApoE4 people. And my sponsor, David Bobbitt's ApoE4 with massive heart disease. And there's some evidence that ApoE4 genotypes who clear fats at a much slower level, if there are ones that are affected with major disease or diabetes or coronary disease, so their metabolism is impaired, may have sensitivities, particularly to dairy or possibly rich saturated fat and high protein foods. So this is something we're teasing out. But even then, that would be an exception to prove the rule. That would be a small, narrow group of diseased ApoE4s who have to be a little careful. So it doesn't have any reflection on the broad, healthy population who just want to avoid disease.
Oh, yeah. And look, don't get me wrong. I think that there are certain situations in medicine where the one size never fits all. And I don't think we should be going around saying everyone should be having as much saturated fat as they like. I think that's a bad message to get out there. I still say to people, the big problem in the modern world as far as health goes is obviously diabetes. And part of diabetes is excessive caloric intake. And if you push the whole Atkins notion, people think, oh, it's okay to have as much bacon and eggs, I just can't have the roll that it's on. So I still think we have to suggest to people you have to keep your calories down, but the mix should be more of just natural foods, of which saturated fat is part of the natural foods.
Yeah, I think that's fair enough. And in a world where I think the figure is 64% of American adults over 45 years of age now, 64% of them are officially pre-diabetic or diabetic. And that's only using glucose measures. So probably 75% of over 45s are essentially diabetic if you measure their insulin and postprandial insulin. So we have such an enormous amount of carbohydrate intolerance now in the populations, the machines are all broken. So, of course, the carbohydrate has to be minimized, and that's going to mean you're going to be eating a little more healthy fat, for sure, yeah.
Totally agree with you.
So, we might circle around back to calcification, Ross, and I mentioned there in our previous correspondence, we have an interesting phenomenon happening in the world. I think it's early days. So the first published paper that showed actual regression of overall calcium score, like Agatston. I know we talked about density of volume, but the actual overall score regressing was, I think, William Wheatbelly Davis, the cardiologist. You know Wheatbelly? And he published a paper with 45 patients and around 20 of them on a low carb with some statin and fish oil, DHA, EPA, and a multi-intervention. He got 20 people to regress, right? Statistically significantly, around 15 or 20%, I think, from memory. And around 20 people of the 45 stabilized and flattened, and a few percent increased. So it was kind of in principle regression showing, which is against the medical dogma that calcification, once you've got it, generally pops up 20% a year and keeps going. And then recently we have people from all around the world who are seeing even bigger drops, like 1,200 down to 850 over a year. I've got 3,600 down to 2,400 over 2 years. I mean, lots of figures. And what they're doing actually is low carb. They're fixing their diabetic dysfunction. They're taking vitamin K2, you know, which is very involved with the management of calcium in the body, but nothing's proven yet. And magnesium, selenium. So what do you think it means for the actual Agatston when you make a sudden healthy lifestyle switch and fix all your blood markers so you do really good stuff, and in the next year or two it substantially drops on the same scanner? What do you think of that?
I think that's regression. I agree with you. And I think it is possible to regress heart disease. And you mentioned things like vitamin K2. The dose is 180 micrograms. You go to the Rotterdam study, show, again, surrogate markers. You see, what annoys me as an integrative cardiologist is that they say, oh, well, you don't have any mortality, morbidity data for things like K2. You don't need it. We're not talking. See, a pharmaceutical drug is like a high-performance motor car, gets you from A to B very quickly, but with the potential of crashing and killing yourself. So you need a lot of rules. You need safety mechanisms in the cars. You've got to make sure they wear seatbelts and all that sort of business. Whereas non-pharmaceutical drugs, the supplements like vitamin K2, for example, are like a bicycle. Get you from A to B much slower, but you just wear a helmet and keep away from cars, and that's all you need to do. So you don't need the same rules for the high-performance motor car as you need for the bicycle, nor do you need the same rules for things like vitamin K2, which in a dose of 180 micrograms a day was shown to improve arterial stiffness and to improve bone strength. But there's no data about osteoporosis or heart attack or sudden cardiac death. For example, everyone who's on a statin, I put onto ubiquinol. Now, ubiquinol is the active version of coenzyme Q10 because there is no doubt, there's a study in Cell Metabolism a couple of years ago showing that the way statins induce myalgias is by depleting the coenzyme Q10, I think it's in the complex 3 in the mitochondria. And so I give all my patients about 100 milligrams of ubiquinol a day with, now wait for this, you mentioned magnesium, with magnesium orotate, which I don't think you can get in Europe, but the orotate actually lifts the CoQ10 up in the mitochondria. I also use another natural substance called bergamot, which comes from bergamot oranges grown on the southern Ionic strip of Italy. And I'm an honorary Calabrian citizen because of my services to the bergamot fruit. And we did a study where we gave people 20 milligrams of rosuvastatin, got their LDL down 56.5%, then cut the rosuvastatin in half to 10, added the bergamot twice a day, which is the juice of the orange, and we got the LDL down 52.5%, but a much bigger rise in HDL and a much bigger drop in triglycerides. And we had published data in the Journal of Clinical Lipidology where we showed a definite shift from small to large LDL. So I think when you do all of these things for your patients, an integrative approach which involves lifestyle change, the appropriate use of statins and other pharmaceutical drugs, and the appropriate use of supplements and nutraceuticals, you can induce a regression in patients, as you've mentioned from the studies you've quoted.
Yeah, no, that's what I believe currently, and I'm currently doing a deep dive on the mechanisms of calcification. Of around 60 papers printed out here and more to come, because I want to explore that the actual regression, if volume and density go down, what are the mechanisms of the calcium leaching back into the physiology? Because it's kind of a new thing. It's not been explored. There's no proven data on it because it's so new. But in the next 10 years, it could be a huge thing to actually have the calcium, ectopic calcium in even stable plaque, just slowly leach back into the system. And we know that magnesium and calcium can be put into bone, sequestered, taken out of bone when they're needed. So I'm just fascinated by this idea of the calcium slowly drifting out of plaque as the inflammatory drivers are gone and the body is healing.
Yeah, well, that's right. But I think we need some calcium there if you've got a substantial amount of fat. But then as you get the fat down, you can take the calcium out as well with things like vitamin K2. So I have an integrative approach that I use with all of my patients where I do focus on all of these areas, not just pick on one. And you've mentioned inflammation, which is also very important. In fact, a colleague of mine here in Australia did a study called the Lodoco trial. So you've got Paul Ridker in Harvard, who's done some really elegant work with canakinumab, and his methotrexate study didn't work, didn't show any benefit. The canakinumab did work in people with strong inflammatory markers, but this colleague of mine, Dr. Mark Nidoff in Perth in Australia, he took a number of people who'd had acute coronary syndromes, gave them 500 micrograms of colchicine as a simple anti-inflammatory, and there was about a 63% reduction in further coronary events just by taking that every day, one tablet a day. Because if you take too much, 20% of people still got diarrhea on one tablet a day. But it's pretty impressive stuff. So it's working on all aspects of the cascade of atherosclerosis. So not just working on fat, but working on blood pressure, working on inflammation, working on thrombosis, working on calcification. So you're giving people a more global approach, which is the way I do it. And like you, I'm seeing significant regression in a number of my patients.
Which is what it's all about. I mean, stabilization is really the key, I guess, Ross. As in, don't keep rising up exponentially straight to your heart event. Stabilize, level off. It's probably 90% of it. But to actually have regression makes a really great goal for people, because your health and your longevity, it's your personal project. And one of the biggest killers is heart disease. And to actually be able to tackle that with an integrative approach with your practitioner and take the actions to stabilize or regress this massive killer. I mean, a lot of people maybe just don't care. They're going to drink Coca-Cola, they're going to smoke cigarettes, like you said. They don't care, and that's fine. But there's hundreds of millions of people, if only they knew, who would grab this with both hands and really be passionate about.
Can I just make 2 points? One is a personal one to you. I had an email the other day from a fellow in Canada saying, I really want to do a Skype consultation with you because I've been listening to Ivor Cummins and he's mentioned you and a few other things. So you're there promoting me even before you met me. But the other point I wanted to make about all this is that a lot of people don't understand this. They think what happens is that your arteries slowly close over from cholesterol. And it's complete nonsense, as you know. What happens is that if you imagine a donut with a hole in the middle, the fat comes out this way as you get remodeling, so you keep the arterial lumen going. And when the fat reaches a critical mass, it suddenly ruptures. Now, the question is, what makes it rupture? And it's got nothing to do with cholesterol or anything else. It's all to do with what I call the 5 stressors. Number 1 is emotional stress. Now, please, Ivor, tell me someone who doesn't have that. So significant emotional stress can rupture a stable plaque and make it unstable. Then physical stress. So I'm not just talking about the physical stress of doing too much exercise. The fat guy that runs for the bus or the train can certainly rupture a plaque, but I'm talking about these lunatics that climb Mount Everest. So it's not just the tall mountains, it's also the freezing cold temperatures and the high altitude and low oxygen. And it's the physical stress of being obese, the physical stress of pain, the physical stress of an operation can rupture a stable plaque. Number 3 is work stress. Now, one of the most elegant studies of work stress has been the Whitehall study that's gone on for years, I'm sure you're well aware, that showed that job strain, which is low control and high demand, those people are the ones who get the cardiovascular disease from work stress. Number 4 is what I call pharmacological stress. Any stimulant, whether it be legal or illegal, is enough to disrupt a fatty plaque. So someone who might have a glass or 2 of wine most days of the week, goes out one night and has 6 or 7, that may be enough to make a stable plaque unstable. I've had one patient, this wasn't so much a heart attack, but for a reason he couldn't explain to me, 35-year-old man, had 3 double-shot cappuccinos in the space of an hour and went into atrial fibrillation. But then there's all this use of illegal drugs. I had a man in his 30s with a very strong family history of heart disease, went out one night with his mates on a bucks party, had a few lines of coke, had a major heart attack. Because as you know, cocaine is I'm not talking about sniffing Coca-Cola, he didn't get the bubbles up his nose, but cocaine is a very severe vasoconstrictor and puts a strain on the wall stress, and he had a major heart attack from that. And then finally, number 5 is infective stress. So you're going along fine, then you get influenza or pneumonia or a tooth abscess or a urinary tract infection. In Australia, we've got a study done at University of New South Wales showing that people who had a yearly flu vaccine had a 30% reduction in heart attack by having a flu vaccine, because you're reducing the inflammation in your arteries. So those 5 keys, I'll just repeat them: emotional, exercise, work, pharmacologic and infective stress can take you from having stable arteries to unstable arteries. So try to avoid stressors as much as you can.
Yeah, it's a fair point for sure. Yeah, whatever about lowering the overall level of disease and increasing stability, also to avoid those more acute stressors, I guess. Though some of those you mentioned there, they might be more arrhythmias and electrical effects, more so maybe than actual plaque rupture at the edge of a
bit of both. A bit of both.
Bit of both.
Yeah.
Excellent.
So is there anything else, Ross? I know you got a hard stop here, and we're coming up. We've done the hour. Anything else you'd add in a general sense of preventative, or anything else on scanning technology?
No, what I'd like to say is that the people I see in my practice who do the best are, number one, best bit of advice I give you, pick the right relatives, because all heart disease is genetic. So pick the right relatives is the best thing. Number 2, follow those 5 keys of being healthy. I'll repeat them. You cannot be healthy and have any addictions, good quality sleep, good quality eating and less of it, 3 to 5 hours a week of exercise and happiness. But number 3, if you are prescribed medications, whether they be natural or unnatural, take them. Because the problem is you line up 100 people, after 12 months, 50% of people have stopped their treatment for whatever reason. And if you are getting side effects, ring your doctor and let your doctor know. I say that to my patients. I don't want to hear that you stopped your medication 6 months ago. If there's a reason you've stopped them, please let me know. And then finally, people who come for regular follow-up, people who have a long-term relationship with a trusted doctor who they can see on a regular basis. And if people follow that, they're covering all bases. They're the people who have the best chance of regression, if indeed they need to have something regress.
Yeah, and they're the people who are motivated for their health, and they're, as you say, doing the right thing. Now, I guess the only caveat there is, if you have a doctor who believes that it's all about the cholesterol and insists on a drug just because you have high cholesterol, that's obviously a challenge. An inappropriate drug, as you well described.
I agree with you, and I think people have to realise that doctors should be 2 things to people. They should be advisors and servants. And if your doctor, if it tells you you're wrong and argues and is rude to you, find another doctor. You're the driver of your own health. You must take charge of your health and ask the right questions, because it's your body. No one else is going to do it.
Excellent, Ross. And you know what? That's a great sentiment to end on. That just about captures it all. And the one last thing I'll get you to say is, I heard a figure you had done a number of calcium scans over the decades, and it sounded pretty huge. Just remind me of that figure.
Yeah, I think we've probably done over the last 20 years somewhere around 50,000 coronary calcium scores. I haven't got the number with me, but I've just multiplied by how many people I've seen. It's around 50,000.
Excellent, Ross. Well, you're well ahead of your time. The 2018 guidelines now have just come out with 2A evidence level. CAC is going to get really big, and you were there decades in advance. So congratulations.
Ivor, it's been an absolute pleasure to talk with you, my friend. Thank you.
Ditto. Thanks a lot, Ross. And we'll catch you again later with some new updates.
Pleasure.
Thanks for tuning in, guys. If you're watching on YouTube, you can see my subscribe button in the middle of the screen, a free viewing of the Widowmaker movie on the far right, and myself and Dr. Gerber's book, Eat Rich, Live Long, on the left. Otherwise, please do subscribe to the audio podcast. Thanks.